Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
May I please request all of our speakers to kindly turn on their cameras to get this webinar started. Yes, thank you very much, Doctor. Thank you very much, Dr. Akila as well. Yes, we have the three of you. Yes, we're all good to go. So very good morning and a happy Sunday to everybody out there. It's a fresh morning and also the time to learn about something that's truly important yet underlying. Hello, everybody. My name is Hiba Mariam, and it's my pleasure and honor in welcoming you all to the webinar on management of heavy menstrual bleeding brought to you by Healthy India, Happy India, a joint initiative by Naruvi Hospitals Vellore and the Hindu to promote a culture of well-being, leading to healthier choices and happier lives. We're extremely happy to have with us three expert doctors who are here to share their insights with us. So firstly, we have Professor Dr. Abraham Peri-menopausal, Senior Consultant, Gyna Oncology, Naruvi Hospitals Vellore. A warm welcome to you, Doctor. Thank you very much for joining us. We also have Dr. Akila Shri, Senior Consultant of Obstetrics and Gynecology, Naruvi Hospitals Vellore. A warm welcome to you as well, ma'am. We also have Dr. Jai Sheila Kamaraj, Consultant, Obstetrics and Gynecology, Naruvi Hospitals Vellore. A warm welcome to you as well, ma'am. So without holding up further, let's get this awesome webinar started. So firstly, to give us a brief introduction about this vast topic, we have Professor Dr. Abraham Peri-menopausal here with us. So firstly, he is a senior consultant in gynecologic oncology in Naruvi Hospitals, Vellore, India, with an MBBS, DGO, MD, MPH, and a fellowship in gynecologic oncology. He has an extensive experience in this field, undoubtedly. He's also a distinguished member of the SGO, IGCS, and more, and he has also served as a past president of AGOI and AOGI in India, contributing significantly to advancements in gynecologic oncology. So warm welcome to you, Doctor. The floor is all yours.
Yeah, I'll share my slides. So today we're going to talk about menstrual disorders, mainly heavy menstrual bleeding. So I will be doing the introduction. So this is very important. All women need to know something about this, and all women might have at some time in their life a menstrual problem. So this is fairly common. So just introduction to the female reproductive tract. So from the outside, we have the vulva or the labia, and then the birth passage known as the vagina, going to the mouth of the uterus known as the cervix, which has got an external opening and an internal opening. And then the uterine cavity, which is lined by the endometrium and the thick muscular layer known as the myometrium, and the outer lining called the serosa. And from the uterine cavity, you have the two tubes, the fallopian tubes, that pick up the eggs from the ovaries. So the ovaries are attached to the uterus on either side, and they release an egg from either side every month. So the menstrual cycle is more than just having the period or the menstrual flow. So the menstruation or the menstrual cycle is actually the interplay of the ovarian cycle and the uterine cycle. So what goes on in the uterus is also controlled by what's going on in the ovary and also from the pituitary gland in the brain. So this is a complex interplay of hormones. From the pituitary, we have something called the FSH and LH hormones. And from the ovaries, the main hormones are the estrogen and progesterone. So the first day of the menstruation, the first day of the bleeding is known as the last menstrual period. And it usually lasts for 3 to 5 days, as shown here in the red circles. And then we have the follicular phase where the lining of the endometrium gets thickened, getting prepared, and the ovulation occurs mid-cycle, and after that the follicle in the ovary known as the follicular cyst ruptures, releases the ovum, and then the corpus luteum gives some hormonal support, secreting progesterone. So if pregnancy occurs, then menstruation does not occur as expected. But if pregnancy does not occur, then the corpus luteum sort of degenerates and the hormonal support is decreased and menstruation happens. So menstruation is actually the shedding of the endometrial lining. That lining that was prepared, that was thickened for the anticipation of pregnancy. If pregnancy does not occur, then it sort of diminishes and is discarded. So these are the phases of the menstrual cycle: the follicular phase, ovulation, and then the luteal phase. And like I said, menstruation is controlled by the hormones, and the follicular development in the ovary is controlled by the FSH and the LH hormones from the pituitary gland, and the estrogen keeps increasing with the thickening of the endometrial lining. And then with the release of the LH, the egg is released. And if pregnancy occurs, then the thick endometrium increases even further. There is the hormonal support continues to maintain the pregnancy. But if there's no pregnancy, then with the decrease in hormonal levels, the menstruation occurs. So this is what shows menstruation followed by the follicular phase, and then the ovulation, the corpus luteum, and then the menses, or the breakdown of the lining. So the normal menstrual cycle lasts from 2 to 7 days. It occurs every 21 to 35 days. So many women are upset if it's delay. They say if it's late by a few days or early by a few days. So it's like the clock, sometimes going a little fast, sometimes going a little slow. So 1 week this way or that way is considered within normal limits. Now, the onset of menstruation occurs in the puberty, usually around 10 to 12 years of age, and this is known as a menarche. And cessation, or the stopping of the menstruation, is known as the menopause, which is again around 50 years of age. But there is a range, when these events happen. How does the bleeding stop? Usually platelets, or these are some of the components in the blood. They form a plug, like a clot formation. And then there are other chemicals like thromboxane, prostacyclin that come into play. And the prostaglandins constricts the blood vessels. And then there is tissue repair. And this enables the bleeding to stop. Women need to be aware of menstrual hygiene to prevent infections, to reduce odors, stay comfortable during a period. So wash your hands before and after using a menstrual pad, change menstrual products regularly, use the lowest absorbency product, discard used menstrual products properly in a appropriate trash can, wear breathable clothing, keep your genital area clean, use unscented hygiene products. Now, the usual menstrual symptoms which women go through every month, blood does not, but usually the blood does not clot. So if it clots, then that means the bleeding is usually excessive. There's usually some pain, cramps, backache, or sometimes called dysmenorrhea, and this happens when there is ovulation. But if there is no ovulation, then the period may be painless. Along with the pelvic pain, we have breast pain or mastalgia, a sense of bloating because of the increasing progesterone levels, and sometimes acne or pimples. Now, what we consider abnormal uterine bleeding is if it lasts more than 7 days, if the blood clots are present, if it is very heavy to stain your clothes or the bed sheet, that is definitely very abnormal. If it is more frequent than 21 days, that is the whole duration of the cycle, less than 21 days. If it is delayed more than 35 days, if there is intermenstrual or post-coital bleeding, these are abnormal. Or if there's a total loss of cyclical pattern, then that again is abnormal. Sometimes there is no structural cause. So it is more of a functional or dysfunctional bleeding. And it may be, we describe it as being heavy or prolonged. It may be very frequent. It may be very irregular. Like I said, intermenstrual bleeding or postmenopausal bleeding. So these are all abnormal patterns of bleeding. And without a pelvic pathology or a structural problem, we call it a dysfunctional or endocrine abnormality. Now, some of the causes for abnormal uterine bleeding are, we consider it age-wise, and Dr. Akila will look at the problems occurring in the adolescent, teenage. So there are anovulation, pelvic infection, coagulopathies, tumors, and so on. Then in the reproductive years, Dr. Jayashila will consider some of these things: pregnancy-related problems, structural problems like fibroids or leiomyopathy, polyps, an ovulatory cycle such as PCOS, use of improper use of hormone products like such as OCP, endometrial hyperplasia, endometrial cancers, not so common in this younger age group. Whereas I will be looking at the older women, older age group, perimenopausal or postmenopausal bleeding, where endometrial hyperplasia, carcinoma, or cancer are more common. Now, when you come to the doctor, we do some investigations, and these will be looked at more detail by Dr. Akila and Dr. Jayashila. And we ask people to maintain a diary because women get worried with 1 or 2 abnormal periods, but we like to see the pattern over a longer period, 6 months, 1 year. So better to keep a diary so that when you come to the clinic, the doctor is able to understand, because the layman's language and what the doctor is thinking may not match. So it's better to show it in actual pictorial or terms. So you can mark the days of bleeding, you can indicate which are heavy, number of pads changed, you can make a notation, and you can mark other things in the fertile period or whatever else when you had sex or coitus. So if you're planning on pregnancy, these diaries are also useful. Or if you're just trying to describe the menstrual pattern, these diaries are very useful. Now, management principles are to determine the goals of treatment based on the age, need to preserve fertility, and so on. We need to document prior treatments and try and establish the cause of the abnormal bleeding. And the general measures would be to control bleeding if currently menstruating. If it's very heavy, then we need to control it. We need to build up the iron reserves, because when you're losing blood, you become very anemic. Your iron levels come down. We need to control the pain, and we may have to give you iron or blood transfusion as needed. To control the bleeding, again, Jayashila and Akila will look at it in more detail, but there are many compounds that could be used. And these are some of them that are listed here, and they have different methods of action. This is for symptom relief. So in conclusion, heavy menstrual bleeding menstrual disorders are a common problem of women right from 12 to 55 or even more. This is a problem that can affect the quality of life and be quite distressing. Hemoglobin level should be kept up with iron or blood transfusion, and disorders specific to adolescents or the reproductive age group or the perimenopausal age group should be considered by and investigated so that appropriate treatment can be given. Various medical and surgical options are available, and treatment is tailored on wishes of the patient as well as the cause of the bleeding. Thank you.
Thank you very much, sir, for giving this webinar a super energetic start. So let's move on to our next speaker. Next up to address us, we have Dr. Akila Shri. She is a senior consultant in obstetrics and gynecology at Naruvi Hospitals, Vellore, bringing over 2 decades of experience in women's healthcare. She completed her MBBS and MD in obstetrics and gynecology from Raja Mutaya Medical College and Hospital in Chidambaram, followed by an advanced training in minimally invasive surgery as well. Her expertise spans high-risk obstetrics, gynecologic surgeries, and minimally invasive procedures, making her a trusted name in women's health. She'll now be addressing us on the topic pubertal menstrual disorders. So welcome, ma'am. Over to you.
Thank you. Good morning to all. Today, my topic is about heavy menstrual flow in adolescent. So first, I should clear about what is normal cycle. It's vary from 21 to 35 days, as I said, and each cycle can last 1 to 7 days durations. If blood loss is more than 30 to 40 ml, it's considered as a normal cycle. So blood loss exceeding more than 80 ml per cycle. If periods is lasting more than 7 days, a person's soak more than 1 pads per hours is considered as a heavy menstrual flow. So it can be a challenging and affect daily life. So causes of heavy menstrual flow are, and first thing is anovulations. And after menarche, usually that hypothalamic pituitary ovarian axis is immature, we can wait for 2 to 3 years for that. So other things are hormonal imbalance like polycystic ovarian disease and uterine fibroid and thyroid dysfunctions like hypo or hyper and genital tuberculosis, obesity and underweight. Both extreme will cause menstrual disturbances, blood clotting disorders and any history of renal and liver disease. So symptoms will be a person soaking through pads or tampons every 1 to 2 hours and need to use multiple sanitary products at once and extreme fatigue and passing clots larger than a quarter and any features of anemia. So how heavy menstrual flow affects adolescents' health and daily life? So it causes emotional distress, discomfort, and absenteeism from school, social impact, and potential for long-term health consequences if untreated. So diagnosis, it started with medical history. So age at menarche and cycle characteristics like timing, durations, frequency, and days lasting for how many days like that. And associated with passing clots or cramps and weight changes like extreme increase in weight or a drastic decrease in weight and history of bleeding diathesis like easy bruising, gum bleeding like that and history of renal and liver disease and family history of bleeding disorders and any drug histories. And in physical examinations, can look for signs of anemia, BMI, and features of hormonal imbalance like excessive facial hair, acne, and blood test to check iron level and liver function test, renal function test, and clotting issues. An ultrasound to check for fibroid or other abnormalities like PCOD, and endometrial biopsy to help to rule out genital tuberculosis. And treatment modalities can be divided into two, that non-hormonal and hormonal. So non-hormonal medications like tranexamic and mefenamic, NSAID can given. Hormonal, we can choose for oral contraceptive pills to regulate the cycle to decrease the bleeding and injectable also available. So iron supplements for anemia. And if its cycle is associated with pain, you can give analgesic. Lifestyle modifications like regular exercise, iron-rich diet, and surgery for fibroid if needed. So tips for managing heavy flow, use of high absorbency sanitary products, staying hydrated and eating iron-rich foods, and keeping track of menstrual cycle to better understand pattern. So when to seek medical help? So cycle is associated with severe pain or cramping, prolonged and excessive bleeding, and any symptoms of anemia, kindly see doctor. Thank you.
Thank you very much, ma'am, for your lovely address. Let's move on to our next speaker. Next up, we have Dr. Jaishila Kamaraj here to address us. She is a senior consultant in obstetrics and gynecology at Naruvi Hospitals, Vellore, with over 23 years of experience in women's health. She completed her MBBS from Raja Mataya Medical College, DGO from Madras Medical College, and MSOG from Christian Medical College, Vellore. Her international experience includes being a research fellow at Sunnybrook Health Sciences, Toronto. She's also a lifetime member of the Indian Menopause Society and a certified Indian menopause practitioner as well. She's also a certified lactation consultant with a passion for high-risk obstetrics and establishing dedicated lactation clinics. She'll now be addressing us on heavy bleeding in the reproductive age. So a warm welcome to you, ma'am. The floor is all yours. Ma'am, you're on mute. Ma'am, your mic is off. You're on mute. No, you're still on mute. I think it went.
Unmute yourself,
Yes.
Jaishila.
Ma'am, you're still on mute. If you can just go back to Zoom and unmute yourself. Just take a moment until ma'am unmutes. Yes, I think you are on unmute now.
Can you hear me now?
Well and clear.
Good morning, everyone. I could see almost 200 attendees. I think I'm very privileged to be among this august audience to present about heavy menstrual bleeding among the reproductive age group. I have put 19 to 45 for the discussion sake. Every fourth woman in my clinic experience heavy menstrual bleeding. So now you can imagine the vast majority of patients go through this morbidity, so that quality of life of a woman becomes obsolete. So we have to be very careful in going through this discussion of heavy menstrual bleeding among the reproductive age group. How much is too much? When is to seek medical help? Excessively long, frequent, unpredictable periods and passing large blood clots. Worrying about having bleeding-related accidents. Changing sanitary protections every 2 hours. It can be a menstrual cup, and napkins, or tampons. Having to change sanitary protection maybe once or twice during night is a concern. Feeling faint or breathless during a period is a concern. And you have to date your social activities and clothing around bleeding and getting worried about staining your clothes during your workplace. And it needs a good clinical history and examination to make the management plan which suits every woman. Age is an important factor to consider the treatment for heavy menstrual bleeding. And parity, whether she has made baby before or going to make baby, it's important to make the management plan. Menstrual history, which has always been discussed by my colleagues. I don't want to go into details, and we have to know about the medical illness background so that we can give the treatment which suits their background. And if she's breastfeeding, or if she's taking any other drugs, or if she's interested to have contraception as well. And I'm going to throw 3 clinical scenarios to start the discussion. Here I have 21-year-old student. She has missed period followed by prolonged and heavy menstrual blood loss. And for the discussion's sake, missed period could be due to PCOD, or unless and proved otherwise, it could be pregnancy. Even though they are student, it's very important in a OPD to make sure whether she's sexually active or not. Now, the social media has given us a lot of awareness for the youngsters to seek medical help in case if they need to be. And we have to be very open and about sexual activity even though they are students. And going into the second scenario, 32-year-old Mrs. X, she's a mother of one child, and she's on birth control pills for her spacing. Now she has come with spotting per vaginum. Here my background is she's on birth control pills, which she has to be very compliant with her pills for us to deviate the discussions. Third cases, 43-year-old Mrs. V has come with irregular cycle and heavy menstrual blood loss. This we have to have a basic background and to look for the cause of the heavy menstrual blood loss, and the management plan depends upon the diagnosis. And first and foremost is rule out pregnancy in any age group, because until pregnancy is ruled out, we can't look for other causes. And going into the evaluation, proper clinical history followed by good clinical examination will give us the skeleton for the management plan. On clinical general examinations, we have to look for the whether she's anemic, how is a BMI, and cardiovascular and respiratory system examination, and per abdominal and pelvic examination. And in case when they are coming with a heavy menstrual blood loss, we can't take pap smear test, but we have to educate them about the cervical cancer screening. We have to do basic blood investigations. First and foremost is hemoglobin, to look whether they are anemic or not, and thyroid stimulating hormone, and the blood group in case if she's anemic and need blood transfusion if she's anemic. And we have to have a basic ultrasound scan to look for the your size of the uterus and the inner layer thickening, whether any structural abnormality in the uterus as well as the ovary. And we have to have an endometrial thickness in case if it's too thick and we can't have a cutoff. And the standard workshop says 12 millimeter, more than 40. It depends upon which part of the cycle they come to us. And hysteroscopy if required. And this is a basic flow chart which gives an idea about what I have already discussed. There are after the proper history and physical examination, after confirming whether it is arising from the uterus or not, we have to classify them whether it's structural or non-structural related, and whether any coagulopathy or endocrine disorders are there, and we have to make a plan along with advanced investigations. And this is a picture showing whether the bleeding is due to structural or non-structural. And this picture will much more able to understand the reasons better. There is FIGO has classified the management into structural and non-structural. PALM is polyp, that's the soft tissue growth from the inner layer of the uterus. Adenomyosis, the second condition. Here I put it in the picture. Adenomyosis is the inner layer supposed to stay in the inner layer. When it goes into the muscle layer and they start bleeding every month, the uterus becomes bulky and they start having excessive bleeding and severe pain during periods. And leiomyoma is a benign muscle tumor which can start in the inner, project into the inner layer or the middle layer or the outer layer, causing pressure symptoms as well as menstrual symptoms to make them uncomfortable. It can be malignancy and inner layer thickening called hyperplasia. And these are the four structural causes which causes heavy menstrual bleeding. And going into the non-structural causes, this is coagulopathy. That means some problem in the bleeding, forming clots, or ovulatory dysfunction, which is the foremost cause nowadays for the heavy menstrual blood loss. They are supposed to ovulate every month around the middle of the cycle, around day 10 to day 17. But if it doesn't happen regularly, they can have a irregular bleeding, which can be short cycle or long cycle. And it can be due to the lot of medicines which it's prescribed for some other. It can be due to anticoagulants for the heart problem. We think it's they are the heart problem can have anticoagulant need, then they can have more bleeding. In case if nothing, then we have to look not otherwise specified. And going into the treatment details, first and foremost, if she is anemic, we have to supplement them with iron, or therapeutic iron infusion also might be needed. And second one is non-hormonal treatment includes non-steroidal anti-inflammatory drugs. Usually what we use meftal for the pain relief, and tranexamic acid. I'll go into details about all the drugs in every slides. NSAIDs, tranexamic acid, progestogens, and stepwise manner, and combined oral contraceptives, injectable progestins, and in levonorgestrel intrauterine device, and ormeloxifene. Going into the non-steroidal anti-inflammatory drugs is the first and foremost drugs which we use every day in our outpatient department. It decreases the menstrual bleeding by almost 20 to 50%, which is simple treatment which decreases the pain and bleeding, and it has to be considered and first and foremost to decrease their symptoms. It decreases the menstrual cramps and used always in combination with other medical treatment while waiting for the other investigations. It doesn't have any contraceptive action, so it can cause indigestion or worsening of asthma and peptic ulcer. You have to have a medical doctor helping you when to start with this. And tranexamic acid is an antifibrinolytic agent. It decreases the menstrual bleeding by almost 60%. Used in combination, along with NSAIDs, it comes as a combination of tropic MF, which can be considered and decreases the blood loss by 60%. It doesn't have any contraceptive action. We can use 1 gram every 6th hourly for up to 5 days during your periods. Maximum 4 gram per day can be given. As I already mentioned, we always combine with NSAID, so it can cause indigestion, sometimes diarrhea, headache, and leg cramps. Consult your doctor in case you have side effects. Progesterone is the first hormonal therapy which we always start without even having to worry about the background. Benefits are decrease the menstrual bleeding about almost 87%. It doesn't have any contraceptive effect. May reduce the ability to conceive while on treatment. May not be appropriate for those trying to conceive, but if it is mandatory, we have to use this tablets. It can cause breast tenderness, mood changes, bloating, acne, headaches, and cycle control. Dosing regimen is norethindrone acetate, 5 milligram. We have to start at the high dose and taper the dose according to the response. Combined oral contraceptive pills, it decreases the menstrual bleeding by 20 to 50%, reduction in pain during periods because it inhibits ovulation, and it makes the premenstrual symptoms better because there is no ovulation. It is useful for regularization of menstrual cycle, no impact on future fertility, but it prevents ovulation, so it has a contraceptive effect. It has breast tenderness, mood changes, fluid retention, and it can cause breakthrough bleeding. Going into the next, levonorgestrel intrauterine system. This has made a breakthrough in the management of heavy menstrual blood loss because those days, 20, 30 years before, where hysterectomy was the last resort, now almost 40 to 50% of hysterectomies has come down because of this wonderful drug, which was priced more. Now, because of wide usage, it has come down by price. It decreased the menstrual bleeding by almost 70 to 97%. It causes absence of period, otherwise called as amenorrhea, which is experienced by 20 to 80% of patients after 1 year of use. It is associated with reduction in menstrual cramps and pain during periods. It doesn't have any impact on future fertility. It can be used as a contraceptive also. Precautions, we have to be, may not be ideal for patients with distorted uterine cavity. That means when there is a fibroid in the inner layer, that's called submucous fibroid, or multiple fibroids, bigger cavity of the uterus is bigger, we can't use this as a contraceptive as well as for the treatment of heavy menstrual blood loss. The treatment varies in these situations. It can cause irregular bleeding during the first 6 months and breast tenderness, acne, cramping, and headaches. We always combine as a dual treatment along. When you start this treatment, we have to have a injectable progesterones or ormeloxifene or combined oral contraceptive to have a good cycle control. Ormeloxifene, this has been it's a non-hormonal drug, causes reduction in menstrual blood loss by almost 80%, improvement in hemoglobin and dysmenorrhea. It's cost effective. Dosing schedule is 60 milligram twice a week for 12 weeks, followed by 60 milligram once a week for 12 weeks. It's a suitable alternative for medical therapy in the management of abnormal uterine bleeding. Side effect is amenorrhea and thick endometrium and irregular bleeding. And going into the next is injectable progesterones. Benefits are it causes amenorrhea, which is experienced by 60% of patients in the first 12 months, 68% by almost 24 months. It has contraceptive efficacy, and the concern is delay in the return to fertility, irregular bleeding, breast tenderness, weight gain, mood changes, decreased bone mineral density. We have to be very cautious in using in adolescent group as well as peri-menopausal because it causes decreased bone mineral density. There is an FDA warning, black box warning. We can't use more than 3 doses in a year. And along with calcium supplementation, you can give this to peri-menopausal age group. The dosage is 150 milligram IM every 3 months. For the completion sake, I've covered danazol because in the outpatient clinic, we see patients taking this treatment. I thought I'll put some insight about this treatment, this drug as well. Danazol decreases the blood reduction by 80%. Amenorrhea is experienced by 20% of patients. They have infrequent periods in about 20%. It doesn't have contraceptive effect, not appropriate for those trying to conceive. It causes weight gain, acne, muscle cramps, GI upset, and irritability. Dosing regimen is 100 to 400 milligram once daily. Going to the GnRH agonist, this is not used routinely, but in some situations, we might have to use this GnRH agonist. It causes amenorrhea, which is experienced by almost 90% of patients within 3 weeks of first injection. It doesn't have any contraceptive role, may not be appropriate for those trying to conceive. It has hypoestrogenic side effects like hot flashes, night sweat, vaginal dryness, bone pain, loss of bone mineral density, and mood changes. And the drugs we use are leupride, acetate, or goserelin, which can be given 1 month doses or 3 month doses, along with add-back therapy, usually combined oral contraceptive pills. And just to, for the completion sake, I'm giving insight about surgical treatment because it's very scope of my talk to talk about surgical treatment in this given time. Hysteroscopy is a special tool to view the inside of the uterus and the polyp and fibroids and the correct uterine abnormalities. The myomectomy is removal of symptomatic myoma. All myomas doesn't need to be removed. In case if it's bothering or causing menstrual disturbances, heavy menstrual blood loss, it might need attention by removal of fibroid. Endometrial ablation, it is a peeling of the inner layer of the uterus by a balloon. But they can have amenorrhea or they can have irregular bleeding, and it needs lot of checklist before considering this treatment. Hysterectomy, it's removal of uterus surgically. The problem is it's a definitive management and it's the management in case if all the other treatment fails. And we have to inform them the women doesn't have periods after the hysterectomy. Take-home messages. To plan therapy, we need good medical history, age, desire for fertility, and the risk factors. Ultimate goal is to identify the cause, treat the underlying cause and anatomical cause. We have to prevent recurrence and we have to treat the anemia, decrease unnecessary surgical intervention, and improve the quality of life of a woman. And we have to tailor the treatment according to the need. Thank you.
Thank you very much, ma'am, for that awesome presentation. It was great listening to you. Before we move on to our next presentation, I see 18 questions on our Q&A box. In case anyone has any more questions, please use this chance to put up them in the Q&A box. And towards the end, we'll have all of our doctors answer them for you. So that's about the questions. And up next to address us on post-menopausal bleeding, we have Professor Dr. Abraham Peter Khalil here with us. So warm welcome to you, sir. The floor is all yours once again.
Yeah, I'll quickly wrap this up. So I call it peri-menopausal, which includes bleeding that occurs during the transition to the menopause. And this, a few years before the actual menopause, anovulation is very common. So the cycles are very irregular. But you need to consult a doctor if the menses are heavy at this time, or if it is delayed by more than 3 months, or if your symptoms are very heavy. So the symptoms of the perimenopause include irregular menses, hot flashes, sleep disturbances, which we usually associate with menopause, could occur a few years earlier also. Mood swings, vaginal dryness, discharge, urinary incontinence, infection, decreased libido, and bone and joint pain. So these are some of the symptoms that you might want to discuss with your doctor. Now, menopause is actually the cessation of menstruation, but sometimes it's difficult to know when exactly that occurs. As doctors, we take it as absence of menses for at least 6 months after ruling out a pregnancy, because sometimes you might get a pregnancy even in your late 40s. So we want to make sure that you're not pregnant, and then the periods have actually stopped. 6 months, 12 months would be even more certain. Problems of the perimenopause, such as bone loss, metabolic changes, become more common and more severe, and bleeding after the menopause, which we call as post-menopausal bleeding, is clearly abnormal, and it should be investigated to rule out cancer. So if you don't have periods after, say, age 45, 48, 50, for 6 months, 1 year, and you have bleeding, please go to the doctor immediately. Now, how do we assess heavy menstruation? Duration of flow, duration of cycle, whether clots are present or not, whether you have stained your underwear, skirt, bedsheet, etc., number of pads. These have been already alluded to by the previous speakers, so I will go on. But we need to know whether you're actually symptomatic, breathless, whether you're able to carry out your home duties, or whether you can walk, climb up the stairs, and so on. And also, we would ask you, what is your lowest hemoglobin level been? And whether you've taken iron supplements or blood transfusion. And in examination, of course, we do a pulse, blood pressure, look for anemia, that's pallor, look into your eyes and see whether it's very pale, or look at your tongue, and then we examine you properly, see if there's any mass that we can feel per abdomen, or we might do an internal examination to see the size of the uterus and so on. And the investigations, which we have already listed out, both I had done it earlier and Dr. Jayashila also had mentioned it. So what do we mean by a cervical smear test. This is a screening test. So we have to look at the cervix, the mouth of the uterus, by putting in what we know as a speculum. And then we put a very soft brush and just twirl it around as shown in this picture. And then we put it on a slide and look under the microscope and look at the cells to see whether any of them are abnormal. So what we are trying to find out is there any pre-cancer or cells that are showing some cancerous change. And these abnormal areas will exfoliate, or these cells fall off easily. And so we can examine them. And what do we mean by endometrial sampling or endometrial biopsy? So basically, we can do it as an outpatient procedure. We pass a small plastic tube into the uterus, and then we use a syringe or some suction mechanism to draw the tissue out. So we get a small bit of tissue, and we put that into the sample jar and send it to the pathologist. What do we mean by ultrasound scan? So this is a painless procedure. We can do it as abdominal scan and see the size of the uterus, the ovaries, and so on. Sometimes to look at it better, we do a vaginal scan where a probe is inserted into the vagina, so we can look at the uterus and ovaries much clearly. And what do we mean by endometrial thickness? So like I said, the endometrial thickness will vary with the phase of the cycle, whether you're follicular phase or premenstrual or luteal phase. And normally, at menstruation or just after menstruation, just 1 to 4 millimeters thick. In the follicular phase, it becomes 5 to 7 millimeters thick, and in the luteal phase, it becomes even thicker, 7 to 14 millimeters. But what is high risk is after the menopause, where there's estrogen has come down, your hormone levels have come down, the lining will be very thin. So normally we expect a very thin lining, but if it is more than 5 millimeters after the menopause, we are worried. So this is what we see on the ultrasound. So on the ultrasound, this is the shape of the uterus, and then we try to measure how thick the endometrial lining is. What are the blood tests that we might do? Yes, hemoglobin, white cell count, renal function, sugars, because in this age group, after a certain age, as you get older, you're more prone for diabetes, thyroid problems. And if you're planning any surgery, you would like to do blood-borne infection screen, liver function, lipid profile, cholesterol, and also vitamin B12, vitamin D. These are all much more common and might contribute to some of the symptoms that you have around the menopause. What do we mean by hysteroscopy? We're looking inside the uterus. We are passing a very thin metal tube or a telescope with a light, and we can look inside. And so what we see is the cavity of the uterus. And to look at it better, we distend the uterus with some fluid, usually some saline. And then we can see the ostia, tubal ostia, where the tubes are attached. And we can see whether there's any growth or polyp or whether the endometrium is in any way abnormal. And in the operating room, we can look at it, or even in the outpatient room, if you're not doing any procedure, just a diagnostic one, we can just look at it on the screen, and that's what it looks like. Now, specific treatment, again, Dr. Jayashila has gone through this, so I'll quickly go through it. Most of the time, there's no pathology. Sometimes we may find a small fibroid or some mild adenomyotic change, whereas what she explained, there's some bleeding into the uterine muscle. So these things we would always start with, mefenamic acid, tranexamic acid, progesterone, such as norethistron, a combined oral contraceptive pill, and the LNG, IUS, which are, or sometimes called the Mirena or Emily. These are some of the what the companies market it as. So in the perimenopausal, we don't like to give hormones for a long time. We might give hormones to control the bleeding, but every time you take hormones and stop it, you will have bleeding. So we try not to give you hormones for too long. We want to see whether whether you're going to get the menopause. If you are at 48, 49, within a year or so, you will attain menopause. So all your menstrual problems should stop. Even if you have some irregular or heavy bleeding, if you can manage with medicines for about a year, then it might resolve on its own. Dr. Jayashila mentioned endometrial ablation, where we might ablate it with different methods to ablate it or even remove the endometrial lining. The LNG IUS also, Dr. Jayashila explained, basically it's like the copper T for contraception. This is also used as a contraception, but it also, there is a steroid reservoir, and the progesterone is released, small amounts every day. And there's a thread on it, so it can be pulled out anytime. So this is how it sits inside the uterus and releases the hormone that acts locally. And it controls the monthly growth of the lining of the uterus. Specific treatments, if we have an endometrial polyp or a submucous fibroid or a very thickened endometrium, we can do a hysteroscopy. And this is known as operative hysteroscopy, where we might be able to remove a polyp or resect the fibroid or just scrape the lining of the uterus, what is known as curettage. Now, suppose there are large fibroids, then again, we might try medications initially to try and control the symptoms, mifepristone, GnRH analogs, but we might have to remove the fibroid, what is known as myomectomy, but we do a myomectomy only in a younger age group when fertility is desired. So in the perimenopausal, menopausal age group, we usually do not do myomectomy. We usually go in for most uterine artery embolization, focused ultrasound ablation, or remove the uterus. And like Rajeshila said, removing the uterus is the last resort. So any refractory case, whatever the cause, we can resort to removing the uterus, which will stop the bleeding. So once we remove the uterus, no bleeding, no pregnancy, the vagina is still preserved, so you can continue sexual function. How do we follow up patients? Patients can be followed up every 3 to 6 months if difficult to manage, or if their medications are working, then you can come back after 6 months or 1 year. We check the hemoglobin periodically to make sure that you don't become anemic. Various treatments may be tried, and we usually do them one after the other, and finally might end up with Mirena, that is the intrauterine device, or we end up with hysterectomy. Now, hysterectomy or removal of the uterus may be done with or without removing the ovaries and tubes. So this is the last resort. It may be done vaginally, that is from below, with or without the pelvic floor repair. It can be done laparoscopically, or it could be done robotically, or by open surgery. So there's not very much difference. There's a lot of hype about endoscopic surgery, laparoscopic, robotic hysterectomies, but you pay much more for these things, and it really doesn't make too much difference. Maybe an extra day in the hospital if you do open surgery, and maybe a little more pain, but pain is usually well controlled with painkillers. Now, in this age group, the older group, when you are after 45, after menopause, endometrial cancer is always a worry. If you have bleeding after the menopause, the risk of cancer is between 10 to 20%, which is too high to ignore. Okay, so 10 to 20, you don't want to take even 1% risk with cancer. Cancer is a disease where you want to detect it early. We want to do something definitive in the first stage itself, in the earliest stage. So go to the doctor immediately. And we diagnosed with an endometrial biopsy. And once we diagnose it, we will need to do proper imaging with CT scan or MRI scan. And the initial treatment is surgery, and we want to stage it. By stage, we mean we want to know where all it has spread. Is it in the uterus, which is first stage, or has it gone to the surrounding tissues, which is second stage? Has it gone into the other pelvic structures, third stage? If it has gone into upper abdomen or outside the abdomen, it is fourth stage. And this cancer has a very good prognosis if detected in the early stage. In first stage, surgery itself will give you 90% cure. So uterine cancer, there are two types. One is the endometrial cancer, which is the lining that we have been talking about. And rarely you might get a cancer in the wall of the uterus from the muscle, which is known as a sarcoma. Now, the treatment options for uterine cancer are surgery. Like I said, it's always surgery first. And then we decide after we get the final biopsy report whether you need chemotherapy, radiation therapy. And now there are more newer agents that have come out called targeted therapy or immunotherapy and so on. So in conclusion, perimenopausal AUB is a common problem of women above the age of 40, 45. And this is a problem that can affect the quality of life, and it can be serious conditions after the menopause. So hemoglobin level should be kept up with iron and blood transfusion. We don't want you to get anemic. Postmenopausal bleeding should be attended to immediately, and cancer should be ruled out by an endometrial biopsy. Various medical and surgical options are available, and treatment is tailored on the wishes of the patient as well as the cause that we have found out. Thank you.
Thank you very much, sir. Firstly, like a virtual applause to the three of you for giving us some great presentations. Thank you very much for sharing all of your thoughts. Let's move on to our discussion part of it because we have about 35 questions. Let's break it down one by one. So firstly, I would go with Dr. Abraham. You spoke a lot about, the cancers and, how we should rule them out to, be on the safer side. But is there 100% cure for endometrial and cervical cancers available? Like a 100% cure for it?
Like I said, in the early stages, it's very, very amenable to cure. But cancer is such a disease where you can't give any 100% guarantee. In pre-cancer, yes. If it's pre-cancer, then we can say 100% chance of cure, both for cervix and endometrium. If it's pre-malignant, sometimes it has not really invaded, gone into the wall, then we can cure it. But in stage 1, it's about 90%.
Oh.
So any cancer, we say, even we tell you it's 90% cured, but there is still a 5 to 10% chance it might come back. So please come for follow-up every 3 months or 6 months for the first 5 years. Any cancer, you have to be careful for the first 5 years.
Yes. Thank you very much, sir, for sharing your thoughts on that. We'll move on to our next points of discussion. So there's somebody who has asked, what is the solution of heavy bleeding and pain during periods? So I think a very common question from a lot of people out here. So if we can get thoughts from any one of you on this question. Yes,
Can
Dr.
I
Jain.
answer, sir?
Please go ahead.
Depends upon the age, and pain needs to be addressed, because every month going through this, it's not easy. So we can use a non-steroidal anti-inflammatory drug, as I already mentioned in the presentation, and that is called, usually give meftelspaz to start with. This is available as 250 milligram. I advise them to take 2 tablets when they start the menstrual cramps, and they can have like a sanitary protection. They always carry along with them. They can have meftelspaz in their bags, personal hygiene bag, so that they can use it whenever needed, 2 tablets at that time. They can use when it's going to be difficult for them to affect the quality of life as a student or as a working woman or at home. And they can use 2 tablets 3 times a day and at least 3 to 5 days. When it's too much bleeding, it actually decreases the bleeding as well as the pain. And when they need more, they can use tranexamic acid combination that is called Trapic MF, so that it decreases much better than just the non-steroidal anti-inflammatory drug meftelspaz. I hope this helps.
Yes, definitely, ma'am. Thank you so much for that answer. We move on to our next question. There's somebody who wants to know, is there any non-medical and non-surgical management of menorrhagia? Any thoughts on that
Yes.
question?
Non-medical and non-surgical would be, like I said, uterine artery embolization or focused ultrasound might help in certain conditions. Of course, things like training your mind, yoga and meditation, all these things, relaxation exercises, these also might help you to cope with the pain. So these are psychological methods to try and cope with pain.
Thank you very much, sir, for that answer. Our next question is to Dr. Akhila, as mentioned. So it says, ma'am, could you please tell me what could be the cause for menstrual bleeding before the age of puberty? So your thoughts on that,
Mm, first thing, after menarche, usually that hormonal will be imbalanced, like that hypothalamic pituitary ovarian axis will be immature. So you can give 2 to 3 years time to settle down. You not to be worried and go and rush on like OC peoples like that. So if due to anovulation, the cycle is irregular. So after 3 years, it will settle down spontaneously. After that, that polycystic ovarian disease is more common nowadays, but it's not like only on the doctor's hand, but patients should also that follows like regular exercise and balanced diet like that. It will help.
Thank you very much, ma'am, for that answer. Our next question goes, what size of fibroid may be managed by medical treatment? So any thoughts on that question? the size of the
Any
fibroid that can be managed in
any
menopausal. Yes,
fibroid, if it is not causing any problem, can be left alone. Any size, if it is not causing pain, if it is not causing bleeding, excessive bleeding, what we call an asymptomatic fibroid, need not be treated. And after the menopause, these fibroids will shrink in size. But if it is causing pain, then if it is causing bleeding, then we have to start with medical treatment, such as the pain medications, the tranexamic acid, and so on. Or there are drugs that can shrink the fibroids also. But some of these medications can be used only for a short period of time because there are some side effects.
yes, thank you
So
very
there
much.
is even a small fibroid can cause problems if it is inside the cavity, even a 1 centimeter. So it depends on size and also on the location. So that is why ultrasound will help in finding out where this fibroid is, how big the fibroid is, and whether anything needs to be done about it.
Absolutely. Thank you very much, doctor, for that answer. Our next question is from a 21-year-old who says that she usually experiences deep cramps, especially on the first 2 days of her period. So what could be the causes of these cramps and what could be done to subdue the pain? So, yes, Dr.
This
Jayashree.
is 21 years old, and obviously she might be a student or just started her career. And as I've already answered this question in the first time, Meftelspas is a non-steroidal anti-inflammatory drug which can be kept along with your bag where you carry. So 2 tablets, that is 500 milligram, can be taken 3 times a day during periods for the first and second period, as she asked. That is, side effects are much lesser and actually makes her quality of life better. And I think this is the first fix. In case if it's too much, then we may have to evaluate any secondary cause, like any ovarian cyst or fibroid, then that needs to be treated according to the location and the size of the cyst.
Just one point, that if
Yes.
you have pain during menstruation, it means that you are ovulating. Okay, so that is part of the natural physiology, that when the ovum is if you're ovulating every month, then that is a little painful. But if you're not ovulating, then the period is usually painless. So sometimes pain is a good sign.
Yes, thank you very much, doctor, for giving us those optimistic thoughts. We move on to our next question. Is there any chance of heavy menstrual bleeding after a gap of 4 to 5 years of menopause? If yes, what could be the cause of it?
Well, any bleeding after the menopause has to be taken very seriously. Like I said, the risk of cancer is 10 to 20%. And the cancer may be in the vulva, vagina, mouth of the uterus, with the cervix, inside the uterus, or in the wall of the uterus. So, but there are other causes. Non-cancer causes also may be there, such as, lack of hormone level. So the lining becomes very thin. So you have what we call atrophy, and some slight ulceration might cause bleeding. So if you have in the menopause, if you have some trauma in the genital area, or from whatever cause, sometimes sexual activity, whatever, then there may be bleeding. Or from the lining of the uterus has also become so thin that it breaks down and there is some bleeding. So that is one very common cause. Or there may be a non-cancerous growth, such as a polyp or thickening of the endometrium. Especially if you're overweight, then there is a lot of hormone production from the fat cells. So that is why, as you grow older, you tend to put on weight. But please, weight has to be controlled, because too much fat is a cause for cancer. So that's one message. Second thing is, don't ignore bleeding after menopause. Rule out cancer, and then there may be some other causes which can be treated.
Yes, absolutely. Thank you very much, sir, for that amazing answer. We move on to our next question. There's someone who wants to know that if a menstrual cycle lasts for only 2 days, is it normal or not?
Yes, just having a spotting itself is enough. But patients are very paranoid about I'm not bleeding more, because during your starting from menarche to menopause, the bleeding cycle pattern doesn't remains the same. So we all have to understand your body changes, pattern changes, the flow also keeps changing. When there is a comparing your prior cycle and now when you are bleeding less, possibility is age-related changes, And number one. Number two is either you have put on weight. PCOD can have oligomenorrhea. So we have to be careful on lifestyle modification and exercises and keeping your weight under control. That might be the treatment probably. And you have to accept the fact the pattern doesn't remain the same throughout your life. It keeps changing. You have to be more open to changes. And in case if it's too much is a worry, too less, if your weight is not increasing, then that shouldn't be a worry. Scanty flow should not be a worry in case if everything is under control. And we have to be thinking about thyroid. Hypothyroidism can have oligomenorrhea as well as too much of bleeding. That means less flow as well as too much of flow. You have to look for, and when the hemoglobin is less, the body wants to preserve iron, so they bleed less. We have to do two tests specifically, hemoglobin and thyroid, and look for weight management in case if they are putting on weight, and need the necessary treatment depending upon the HB and thyroid.
Yes,
Could I just
doctor,
add
you
on,
had.
could I just
Yes.
add something there? I mean, see, women get worried if the bleeding is less. Any bleeding every month is fine. Accept it. I mean, even a spotting is fine. That's not bad. I mean, you have a misconception that bad blood is accumulating inside you and it is not coming out and it is going to poison you. All that is myth. Okay. So again, women get worried. I'm not, it's coming 5 days late. It's coming 10 days late. As long as you get fairly regular periods, it's fine. Okay. So I ask women, do you want a period every week? Do you want a period every 2 weeks? Do you want a period every 3 weeks? As long as you get a period which is not heavy, once in 3 months is fine. Up to 2 to 3 months, as long as it's not heavy. But if you're getting delayed periods for more than 3 months, you should get evaluated. Or if you don't get periods at all, you should get evaluated. But as long as you get some bleeding, that's fine.
Thank you very much, sir, for busting some myths as well as some great knowledge pouring on this Sunday. We'll move on to our next question. It says, I'm 28, I'm unmarried. Is it biologically true that fertility rate decreases with age? If yes, can you mention the nominal fertility age for women?
Of course, when you grow older, your fertility decreases, but the age cutoff, we can say more than 35. But nowadays, even I have seen a lady with 25, 30 with low ovarian reserve. If they have a surgery before, that means on the ovary, and it decreases the fertility more than the women who have never had a surgery. So obviously, there is a fertility period and where the eggs counts are very good. Women are born with a basket of eggs when they are in the mother's womb. And as you age more and your egg quantity comes down, obviously quality of the eggs also comes down. So plan your fertility plans during the peak age group between 20 to 35. And in case if you want to postpone, plan properly so that you won't end up in assisted reproductive techniques. Thank you.
Thank you, ma'am, for sharing your thoughts on that. Our next question is quite lengthy, so let's see how it goes. It says, I'm 32 years old, unmarried, not sexually active. I have irregular periods since childbirth. Initially, it was delayed for just 1 month, but later it increased to up to 6 months. 2 years ago, I watched a video in which the doctor said to avoid sugar. I practiced it, and from the last 1.5 years, I'm getting my periods regularly. But in the last 3 months, my periods last for 10 days, which is not heavy, but mostly just spotting. I also have some facial hair. Should I consult a doctor about this, and what should I do? So, your thoughts on that?
Ultimately, what I could understand is her irregular periods, and it has become irregular, now regular, and now spotting, and now she has got a hair growth. That means PCOD, polycystic ovarian disease. Whenever there's PCOD, androgen component is more. So they have scanty flow or spotting only, and along with hair growth, excessive hair growth. That means it's a sign that she's got androgen in her body. She needs to consult the doctor. In case if she's put on weight, she has to be careful about weight gain and diet and lifestyle modification if need to be.
Very much, ma'am, for your answer. I think we can take. You want to say something, ma'am? Any other thoughts? Okay, got it. So,
Might add on.
okay. So, you want to add any other points?
No, like I said, 6 months delay is too much. Up to 3 months is okay because along with she probably has anovulation, like Dr. Jayasila said, polycystic ovaries means the egg is not being released, so the cysts remain. So that's what polycystic ovarian disease is. So she's not ovulating. That is one. But if it is too delayed, then the endometrium lining gets thick, and there may be hyperplasia and some other early cancer changes can happen. So better to rule out that she will need evaluation. So up to 3 months delay is okay. In her case, it is not heavy, so that's good. But it is delayed to more than 3 months. 3 to 6 months delay is too much. So she needs. It might be that she's overweight. So cutting sugar is good. She has to cut out all things white: rice, potato, milk. I mean, and all these sugar and flour and all that.
Pretty will help. So thank you very much for giving us that answer. We'll take two more questions and then we will call this a day. So our next question goes, is there any connection between HRT and occurrence of breast cancer?
Yes, by HRT, see, because of the menopause, we have women get these many what we call vasomotor symptoms: sweating, hot flashes, joint pains, backache. So if it's very severe, we try to give them a low dose of hormones. If the uterus is present, we would like to give estrogen progesterone combination or some other drug, such as there are some other drugs also that could be considered. But if the uterus is not there, we can give only small dose of estrogen. But unfortunately, estrogen and progesterone have an effect on the breast. So too much hormones will increase your risk of breast tumors growing. So before we give hormone replacement treatment or HRT, we always screen for breast, uh, both by examination of the breast and also by mammogram. Make sure that there is no tumor there, because we don't want to feed the tumor with the hormones. And even if we give hormones, we give it for a short period. 3 to 5 years usually does not increase the risk. But prolonged use of HRT for more than 5, 10 years definitely increases the risk of breast tumors.
You
There
want to
is
add?
a checklist. We have to be very careful in choosing the hormones for the patients when there is a background history of breast cancer and any breast lesions before. We have to be very careful in prescription, and we have to create an awareness that family history of cancer, especially progestrogens, better to be avoided, and we have to be following them with the screening procedures.
Yes, thank you very much, ma'am, for that. I think we'll take our last question where all three of us can give some thoughts on that. So I'm going to summarize it up since it's quite lengthy. So this person wants to know, what are the advantages of using menstrual cups to using the regular sanitary pads? So what are your thoughts on that? Maybe we could start with Dr. Akila first and then move on to the advantages and disadvantages of using menstrual cups.
So you should actually, it's depending upon the size, we can use it. And just sterilize properly. So before using, just wash your hand, and after using, keep sanitation properly. And it will be useful only, but repeated changing. But it's not properly fixed means it will spill off. So size is very important. Nowadays, it's very useful.
Yes, thank you very much. Yes, Dr.
In my
Jayashree.
OPD, I have started seeing patients using menstrual cups. It's becoming very common nowadays, and people are very passionate. Started looking forward for what knowledge they are going to gain by menstrual cups. It's very eco-friendly and environment-friendly because it doesn't harm the earth, number one. Number two, and we have to choose a right cup. And for the adolescent group, I don't prescribe because younger age, they'll be spending time in the schools. It's not really friendly. Probably once you get married, when you're sexually active, it becomes easy for you to use it comfortably. And we have to be, it's easy because you don't have to carry anything more in your handbag. And once you start comfortably and change once it becomes, sometimes it spills too, as Dr. Akila has mentioned, and clean hands before when you have a good washroom, and it's ideal. In case when you don't have all such facilities, better to go for the sanitary napkins, which is being time tested. And I think the size of cup has to be decided by trial and error, and your doctor can help with that.
Thank you, ma'am, for that. And any closing thoughts, Dr. Abraham, from your end?
This topic, I think like contraception, these menstrual aids, they have different advantages and disadvantages. And I think Dr. Jeshila very well covered. The advantage of the cup is that you can recycle, reuse, and those who are environmentally conscious would love it. But of course, you have to get the right size and so on. When you choose a pad, then the how much they absorb, whether they are winged or not, and all that. I mean, I think you women are much more expert, and I should be the last person advising you on all these things. But I think either of them, whatever is a personal preference and what you really want to are looking for, I think you choose that.
Yes, great thoughts from the three of you. So firstly, thank you very much to you three of you for coming here today and sharing your thoughts with us. A big thanks to the audience for joining us on a Sunday, like I had mentioned, to come and learn on something super important. We have about 60 questions. So all those who haven't got your questions answered, you will get them answered via email. So don't worry about that. All your questions are being directed to our experts and you will get answers. And with that, we come to the end of this highly resourceful webinar. Hence, this was a webinar on management of heavy menstrual bleeding brought to you by Healthy India, Happy India, a joint initiative by Naruvi Hospitals, Vellore and The Hindu. Thank you all. Have an awesome Sunday ahead. And of course, don't forget to stay happy and stay healthy. Thank you so much and see you all very soon.
Thank you.
Videos history. Okay.